My talk is going to be sort of to head this up in the area of methods and metrics for mapping ectasia risk. So there'll be subsequent talks talking more about biomechanics and ectasia, but just what are we doing now with laser vision correction with regard to avoiding this problem of ectasia. I'm currently the department chairman at the University of Nebraska and director of the Trolson Eye Institute, and I have no financial interest in topography or tomography. So really, corneal ectasia is a progressive weakening of the collagen lamellae, and it's a matter of the structure and the function. So when the structure is appropriate and the collagen fibers are appropriately weaving together with proper ground substance and agents within, then you're going to have a stable cornea that's going to be able to undergo surgery without any risk for structural weakening. But laser vision correction cuts and ablates corneal lamellae. And so when do we know that we're in a safe zone for treating patients with LASIK based on the depth of our treatments, based on the thickness of the cornea, based on the shape, and what it's telling us about what's happening biomechanically. So I wanted to kind of go over the question of screening of post-LASIK ectasia risk by number one, looking at what we've really done in the past. Number two, what are we doing now in the present? And then what might we be doing in the future, number three. So in the past, it really was more of a function of surface topography, looking at age, and then looking at depth of tissue removal. And this has kind of been a thumb rule of mine over 20 years or so of doing laser vision correction is the topography normal? What I would normally do is look at the shape and rule out any kind of contact lens related warpage. You want to make sure you're out of contact lenses for a sufficient period of time. There's no dry eyes. You want to make sure the data is good and is not being influenced by any external sources. Number two is you want to kind of look and say, is the inferior to superior ratio difference in a normal range? In other words, the steepest K in 5 locations inferiorly, is it sufficiently greater than that superiorly? Because that's where keratoconus tends to manifest itself with inferior steepening. You also want to look for skewed radial axis so that if there is astigmatism, is it orthogonal or within one meridian, or are there 2 hemimeridians that are less than 90 degrees apart that might be defining that? You also want to look at the steepest K, because anything that's above 47 or 48 is potentially in an area that might be abnormal, and you really need to drill that down. And then number 5 is just looking at topography changes over time. So having one static measurement of a topographic map is not always the best thing. You want to see that there's stable refraction, and in some cases you want to see that there's a stable topographic map that's showing no changes over time. And then number 6 is where I get into more of the advanced imaging methods and evaluation of tomography, which we'll go into as we go forward. So early on in the process, Brad Randleman put together this quantitative assessment of risk, looking at topography, age, and depth, and came up with these 5 parameters that he then scored with different numerical values. And that would give an overall number, which would tell you whether you were a potential risk or not. This was done based on looking at those eyes that developed ectasia and then going back and seeing some of the observations that were between them. And here you can see for topography, it was the inferior steepening and the skewed radial axis that gave a significant value to be considered. And of course, form first keratoconus was even higher. Here you can see that having a score of 3 overall for all 5 categories would be proceed with caution or consider a special informed consent, maybe do PRK, and 4 or more, do not perform LASIK, and the safety of PRK was not established. Now, over the course of time, we realized that maybe the thickness part of it, the residual stromal bed and all, was not only just an absolute number, but maybe a percentage of the tissue that was actually removed. And So one of my former fellows, Marconi Santiago, came up with percent tissue altered, which has to do with the flap thickness and the ablation depth divided by the total corneal thickness, and that tells you how much tissue was altered. And if you went above a certain percent, you might be going at risk. Here's a nice paper where he looked at this together with topographic maps showing in cases where he was below 40% percentage tissue altered, there was no ectasia. In some cases where the map showed more suspicion or low suspicion or normal topography, if he was higher than 40%, he was seeing some ectasia. And so this would kind of suggest that maybe 40% was more of a cutoff. And this is used by many surgeons now to look and see if it's a safe amount to treat. In light of that, Steve Schallhorn put together a large data set out of Europe, out of 300,000 eyes, of which 199 developed ectasia, and then looked at all the maps and all the different metrics and did odds ratio analysis to say that if you had form first keratoconus preoperatively, you had a 20 times greater risk of developing ectasia post-op. If you had some of the IS ratio or skewed radial axis, you had a 5-fold increase in risk. And even age under 30 years, all by itself, gave a 2.5 greater risk. Adding age with that skewed radial axis or inferior IS ratio increased the overall percentage. Interestingly, he saw no correlation with the PTA or the thickness values overall. And this is just saying that these were all patients that were done with standard treatments of preserving at least 250 microns of residual stroma. So that kind of adds an interesting thing to suggest maybe topography and age has a bigger impact than even thickness. So where are we at present is really of tomographic indices. Tomography really looks at front and back surface thickness or curvature and the thickness in between. And by giving this information, you can see elevation or asymmetries that tell us about whether the cornea is normal or not. Here's just a case of a topography where you can see a little bit of a asymmetric astigmatism, a little bit of inferior steepening. Maybe you could say that this is a asymmetric bow tie, which is a lower score on the Randleman criteria. Older patient, 57 years old, stable refraction for several years. Thickness looks okay overall. So is this a normal patient? Would this be a patient we should go ahead and treat? Here you can see asymmetric bow tie, only a score of 1 would fit within the Randleman criteria. If we look with early tomography devices, we could also see, yeah, it looks pretty good. Maybe there's a little bit of steepness in the back here, but nothing looks earth-shattering that would come to bear. However, if we look at the fellow eye of this patient, we can see what's clearly looking like keratoconus. Steepness down below, inferior steepening versus superior flattening. The steepest K is 49. The thinnest pack is even thinner. And we know because one eye has keratoconus, the other one has the risk of keratoconus as well. So how do we better screen out that first eye that I showed where the metrics might not have really otherwise showed it? So Galilei has come up with a tomography that has a reference surface comparison that helps to drill down on subtle back surface abnormalities. And here you can see the right eye of this same patient, which does show a posterior surface abnormality or best fit spherical surface on the back that's slightly elevated here. And then the left eye is much more significantly elevated. If you looked at it with a best fit toric asphere, which is getting rid of all the toricity in the back surface and any asphericity there, that would just show the abnormalities of height. It clearly defines that there is an elevation here down and below relative to slightly superiorly. And that value between those numbers is of a high enough value that it should have been a red flag in terms of the metrics. And you can see obviously the large value in the left eye. So this was published and received the Troutman Award for the best paper in the Journal of Refractive Surgery back in 2013. And it was all about just creating reference surfaces that could analyze it. And if we look at best fit spheres, we're kind of looking at areas that are seeing extra noise in trying to create that best fit. Whereas if we can get it more toric asphere, we can see less of that noise and drill down the actual abnormalities or elevations on the back surface. And you can see that here where you can't really tell much here, but when you look at it with the best fit toric asphere, it's showing more prominent back surface elevation, which puts things at higher risk. Here, based on the criteria, if you saw an AAI, which was the difference between the elevation, highest elevation point versus the highest depression point of more than 21.5, that was proceeding with caution. And you can see by the numbers before that, that certainly made sense. But then Pentacam has also provided certain metrics that we can use, and they've become some of the most popular metrics in the field right now. Here's just another example of a patient who has some slight inferior steepening, asymmetric bow tie with normal thickness and normal age. And if you looked at the overall maps, you could see, looking at front surface elevation, back surface elevation, progression index of the corneal thickness, the thinnest pachymetry, and then sort of a hybrid between some of these metrics. Looking at all of these and then combining them statistically, we can come up with what we call a BAD D-score, which if it's above a 1.6 value means caution, and above a 3 value means stop. And this has been a metric that most surgeons are really looking at and using right now. So here we have a case that might be somewhat suspicious because there is a little bit of an asymmetric bow tie looking almost like inferior steepening. It might have a higher IS ratio based on some of the former ways of looking at it. Is it safe to do LASIK on this patient? Well, if we look at that D-score on the back surface, it says 1.39. That's less than 1.6, so it seems like it's safe, but we've kind of seen this before. What's the other eye look like? You know, are we confident as we move forward? Well, we can drill down on some of these, and some of this technology is now looking in more sophistication at OCT to not only look at total thickness of the cornea, but to look at epithelial thickness, and you can even use it for looking at flap thickness. So in this particular patient, we did an epithelial thickness map analysis, which showed a little bit more steepening of the epithelium down below where it was thicker or where it was steeper. And this told us that it was safe to do LASIK because it wasn't doing what keratoconus would show, which is a localized thinning of the epithelium on the top of the cone. Here's a case of normal where you can see it's a little bit thicker down below. And here's a case of keratoconus where you can see thinning in the overall thickness, and then a lot of thinning and the epithelial thickness that suggests that there's an abnormality based on the epithelium getting thinner on top of the steepest area. Compare that with corneal warpage, where you see this is just not keratoconus, but warpage. Here you look at the epithelial thickness map and it's a little thicker, suggesting that it's warpage and not keratoconus. So these are also tools that are very helpful. Finally, going into the future overall, measuring biomechanics and beyond is really where the future holds. We've seen over the course of the last 10 years or so, the ORA and then more recently the Corvus are air puff-based devices that will look and try to measure a biomechanical response, which is also IOP dependent. So there's a lot of complexity here with those kind of measurements. It doesn't directly measure elastic modulus, but it gives some information toward that effect. With
Dr. Krueger, you're at your time, so we can wrap this one up. That'd be great.
All right, I'll wrap this up. So just going through with Corvus, it's more of a biomechanical methodology, and I'll flip through this because Dr. Cynthia Roberts will go through things further. And that's just to say there's also technologies coming with other biomechanical metrics such as OCT elastography and Brion microscopy, which are not clinically used now, but are promising for the future. So in conclusion, with ectasia detection sensitivity, just looking at the eye and detecting keratoconus is not enough. Topographic is helpful, but we'd like to go further and looking at tomographic indices. If we can drill down and get to biomechanical indices, it's even better. And who knows where the future holds. Maybe we'll even start looking at biomechanical markers such as lysyl oxidase and other natural cross-linkers, which help us to determine where the cornea is at. So thank you for your attention.